Dear viewer, thanks for taking the time by joining this presentation. My name is Menno de Rie. I'm a professor and dermatologist at the University Medical Center in Amsterdam in the Netherlands, and today I'd like to discuss with you the treatment of severe psoriasis in adult patients. Before I start, I'd like to share with you my conflicts of interest and my personal background as displayed on this slide. In this presentation I will give you, after a short introduction, facts of adult life that influence the selection for therapies, the management of patients with severe psoriasis, and some concluding remarks. Psoriasis is a very heterogeneous disease with very many clinical manifestations. Next to the plaque-type psoriasis, patients can become erythrodermic, they can have scalp lesions, their joints can be affected, also the nails, usually in combination with psoriatic arthritis, and patients can also have intertriginous lesions. Other types of psoriasis are the pustular types of psoriasis, the types of psoriasis that affect the hands and the feet, the palmoplantar and pustular types, the lesions on the fingers, and also the lesions in children that can be very much like atopic dermatitis that sometimes are mistaken for that, and then of course the genital lesions. Fortunately, we have nowadays lots of treatment modalities next to the well-known topical therapies, the emollients, corticosteroids and the vitamin D3 analogs. We also can use phototherapy. Nowadays, narrowband UVB is the most popular form of phototherapy used. And then we have the classical oral systemic therapies, methotrexate, cyclosporin, acitretin, fumarates, and apremilast, and the most recent one from the family of TYK2 inhibitors, the deucravacitinib. And the other biologics are displayed on the next slide. Here are listed the biologic therapies, the anti-TNFs, adalimumab, certolizumab, etanercept, infliximab, the anti-IL-17 biologics, brodalumab, ixekizumab, secukinumab and bimekizumab, and the anti-IL-23 biologics, guselkumab, risankizumab, tildacertizumab and ustekinumab. Above these biologics you see the classical oral systemic therapies, their maintenance dose in adults and their PASI 75, although not all of them have been studied in great detail and in the way that we do nowadays with our biologic therapies. But in general you see that methotrexate can give to a PASI 75 for about 36%. At week 16, apremilast 33%, and cyclosporin after 8 weeks leads to a PASI 75 in about 65% of the patients. Fumarates 37% by week 16 and acitretin 47% by week 16. But I must tell you that these figures are not very accurate. So we do have a lot of treatment modalities nowadays, but we also have patients that are different, and we have to take into considerations the different factors, personal factors that influence the choice of treatment for these patients. So when do we start at topicals or systemic or biologic therapy? When do we start anyhow? What's about the efficacy and the drug survival of these drugs? And there are lots of other factors that I will discuss later in my presentation. In the past there have been lots of discussions about when to start systemic or biologic therapies. Different so-called rules were used, And the IPC a couple of years ago decided to organize a Delphi consensus, and based on this Delphi consensus, a paper was published, as presented in this slide, about classification of candidates for topical therapies or candidates for systemic therapy. And from this Delphi consensus, it was clear that patients that are candidates for systemic therapies are patients who meet at least one of the following criteria. Their psoriasis affecting at least 10% of their body surface, and the disease involves special areas, or there's a failure of topical therapies. The factors that I mentioned on the previous slide are given here in more detail. Like I said, body surface area 10%, but there are also other factors that are important to select patients for systemic therapies. PASI, PGA, DLQI, severe psoriasis, failure of topical and phototherapies, or when high impact sites are affected. And which are the high impact sites? The face, the nails, the genitalia, the scalp, palmoplantar regions, and the intravenous skin. So if one of these factors, these criteria, are met, then a patient is a candidate for systemic therapy. How about the efficacy of these new biologics? Well, the IL-17 inhibitors and the IL-23 inhibitors are at this moment more effective than the TNF inhibitors. And in this slide, I show you the PASI 75 and the PASI 90 that can be achieved with these biologics. So nowadays we are able, with some of these biologics, to reach almost 90% of the patients to reach a PASI 90, which is really quite an achievement comparing to where we started 15 or 20 years ago. Another important factor when selecting a biologic is, of course, the survival curve for discontinuation associated with the ineffectiveness. And there's quite a difference between the biologicals that are on the market. As you can see in this slide, adalimumab is the drug with the worst survival curve, and that's probably related to development of anti-drug antibodies. And guselkumab is the most favorable one from the ones that are shown in this slide. Other important factors that are important to take care of when you select a therapy for your patients are factors related to the comorbidities, vaccination status, and pregnancy wish or paternal wish of your patient. For the selection of conventional systemic treatments in special circumstances, I'd like to take you to the EDF guidelines for psoriasis. And these guidelines, a summary is shown over here, where the dark green shows which is probably the best choice and the red ones the worst choice you can make. So if you take a look on the left side of the slide, you see that when a patient has a psoriatic arthritis, then from the conventional systemic therapies, methotrexate is probably the best one you can select. So going down to this slide, you see which are the better ones to select when your patient is suffering from inflammatory bowel disease, when a patient is suffering from diabetes, dyslipidemia, advanced heart failure. And at the bottom you see which one not to select when your patient wants to become pregnant, especially acitretin, methotrexate, and probably also fumarates are contraindicated in that case. How about the biologics in these special circumstances? And this is shown on this slide. When a patient is suffering from concomitant psoriatic arthritis, probably TNF inhibitors, IL-12, IL-23 are probably good to prescribe. For chronic inflammatory bowel disease, the TNF inhibitors are a good choice in contrast to the anti-IL-17 biologics. And for diabetes and dyslipidemia, there is no clear guideline for what to prescribe. If your patient is suffering from advanced heart failure, then it's advised not to prescribe TNF inhibitors, but the other biologicals are then indicated for heart disease, other heart disease like ischemic heart disease. Probably all of the biologics are okay. And when your patient is suffering from concomitant, latent or treated TB, then it's not wise to prescribe the TNF inhibitors. For pregnancy, certolizumab is probably the only one that's really safe and has been tested. The EDF guidelines also give you an indication of the time between stop of treatment and conception, and these are data taken from the SMPCs, and you see here on this slide there's quite a difference in the time between stop of treatment and conceptions of the different biologics. For infliximab it's indicated to have an interval of 6 months, and for, like I said, for certolizumab it can be used also during pregnancy. How about paternal use of conventional systemic therapies? And here it's recommended that men discontinue methotrexate 3 months before attempting conception. Regarding biologics and paternal use, there has been no evidence found that there's any impairment in fertility during paternal use for any of the biologics that are on the market nowadays. With respect to vaccination and use of systemic or biologic treatment, it is advised to check the status of vaccination before starting a therapy. That vaccines can be given with any kind of systemic or biologic therapies. Live vaccines, including measles, mumps, rubella and varicella, can be used in patients receiving acitretin, apremilast and fumarates. Live vaccines are contraindicated in psoriasis patients treated with cyclosporine, methotrexate, TNF agonist and IL-17 inhibitors. Data have been produced showing that vaccination can be given even during psoriasis treatment with any of the biologics, and it's also recommended to vaccinate people with psoriasis with approved COVID-19 vaccines. In the next slides, I'd like to discuss with you some of the comorbidities that we encounter in our psoriasis patients and that have an influence on the selection of treatment. Especially, I'd like to discuss with you the metabolic syndrome, including obesity, hypertension, atherosclerosis, and diabetes type 2. Already 10 years ago, it has been shown and published that there is a negative correlation between psoriasis and metabolic syndrome, meaning that patients that have a high body index also have more severe psoriasis, and the same is true for blood pressure, higher blood pressure, more severe psoriasis. Diabetes, more diabetes, higher glucose also has an effect on psoriasis, and you'll find more patients that have moderate or severe psoriasis. An important comorbidity recognized in patients with moderate to severe psoriasis is depression. And it's clear from data produced from different studies that this is also influenced by obesity, by mediators that we recognized in the skin, in the pathogenesis of psoriasis, the symptoms of psoriasis, itch and pain, and trigger factors like stress. All these factors together can have a severe effect on our brain, leading to depression in our patients. We as dermatologists can play an important role in identifying these comorbidities. We have to check our patients for biologic therapies, for our lipids, for their blood pressure, and do also measurements regarding their weight, etc., etc. And therefore we are the first who can identify risk factors for the metabolic syndrome, for depression, etc., etc. It is therefore important for us to work in a multidisciplinary way together with rheumatologists, with cardiologists, with the GPs, with people who can help patients have a better lifestyle, better food, do more exercise, etc., etc. A question that is often raised is, when do you start your therapies? And does it make sense to start early to prevent more severe disease? From an immunological point of view, it makes a lot of sense to start early, because we have an immunological memory. In our skin we have about 1 billion resident memory T cells. And these T cells have the memory of infectious diseases that we encountered in the past, but also pathological conditions like psoriasis. I will show you on the next slide. When our body and our immune system identifies certain pathogens, they develop TRMs, so resident memory T cells, that can become reactivated if we encounter the same pathogen again. But the same is unfortunately also true for other diseases, allergens, and autoantibody exposure. And we have the same kind of memory with TRMs in our skin for these diseases. It has been shown by different studies that even after successful treatment of psoriasis, some of these resident memory T cells stay in our skin, although the lesions are completely resolved. And when the disease is triggered again, these TRMs are reactivated, leading to the recruitment of circulating T cells and a clinical relapse. It's therefore important that we prevent the accumulation of TRMs in our skin. Moreover, it has been shown that these resident memory T cells may circulate and lead to psoriatic arthritis. The arguments to start an early treatment are summarized on this slide, and as I showed you in the previous slides already, the TRM cells can stay in the epidermis even after successful treatment of psoriasis, and they can be reactivated and drive the recurrence of psoriatic lesions. It has also been shown that inhibition of interleukin-23 results in a reduction of the pro-inflammatory Th17 biomarkers and to a reduction also of TRM cells. There are a lot of factors that influence the selection of the proper treatment for your patients. Some of these are indicated and listed on this slide. For instance, the financial consequences of your treatment, regulatory constraints, etc., etc. But I do want to stress the importance of the patient's preferences in selecting the optimal treatment for your patient. I've almost come to the end of my presentation, and here's an overview of the management of adult psoriasis patients, and a summary of some of the things that are already mentioned. There are things we cannot change, for instance, the genetic predisposition of our patients, but there are lots of other factors that we can influence. We can discuss risk factors and try to see whether we can modify them. The same is true for trigger factors like stress, the use of drugs, etc., etc. I discussed with you the comorbidities, and we have a lot of comorbidities work together. They enhance and can lead to depression, etc. And treatment of your patients is not only treatment of the psoriasis skin lesions or the psoriatic arthritis, but I think it's important to consider all of these factors and work in a multidisciplinary way to select the optimal treatment and prevention of more severe disease in your psoriasis patient. So in summary, here are my considerations for treatment of adult psoriasis patients. Select the optimal treatment modalities. Use guidelines. Lots of guidelines are available. Start early treatment. I've showed you from an immunological point of view the relevance of doing that. Have attention for comorbidities. Work in a multidisciplinary way to see whether you can influence these comorbidities in a positive way. Check your vaccination status of your patients before systemic treatment, and also consider pregnancy risk, paternity risk, etc. Thank you. And with this, I'd like to close my presentation and thank you for your attention. I just want to mention that we have 2 important EADV meetings this year, one in May on Malta and the EADV Congress in Amsterdam, where there will also be an IPC meeting. Thank you very much for your attention.